Hey and welcome to the EYFDM Podcast, brought to you by the EYFDM Podcast team. This podcast is accompanied by a study on listening behavior. Nadine, what's the study about?
Hey Fabian, I'm always listening to podcasts when I'm on my way to university every day. And I'm sure most of you are listening to podcasts too in your everyday life. But have you ever wondered how different podcasts influence your career choices or your personal life?
Well, if you want to find out more about the study, there's a link underneath this podcast in the bio. And now,
have fun with our EYFDM podcast.
Hello and welcome back to the 8th episode of the EYFDM podcast. My name is Fabian and today we are recording from Zwolle in the Netherlands. And I've been kindly welcomed to the home of Dr. Nicholas Mamo, who you might know as our former president of the EYFDM network. Thanks, Nick, for having me today.
Thank you very much, and please call me Nick.
Thanks, Nick. So many of you might know Nick as the president, or as it's formally called now, the immediate past president. But Nick is actually originally from Malta, where he did his undergraduate medical education, and then for some reason decided to do postgraduate training, so his GP training in the UK. And then, because that wasn't enough, decided to do a PhD in the Netherlands, going via London to the Netherlands. So that's going to be a few career choices that are quite interesting to discuss, I think. Yeah, Nick, when you started in Malta, what was it like being a student in Malta?
I have to say, it comes from like a very big position of privilege because it's, the education there is still free. So going to university, I don't have to pay tuition fees. We even get a small stipend every month, and I could live with my parents. So it was a bit of a no-brainer choice. But also, there's a great community. It's hard to kind of say what it's like because, you can just go off to the beach in the afternoons, and it's really nice in that way. But I guess, this might kind of answer a bit of the question of why I decided to go to the UK. It's a small place. So everyone knows everyone, and that has its advantages. It also has its disadvantages. It's nice to kind of see different places, work with different people. And yes, I can see the allure of staying in Malta and working there. It's safe, it's stable. But it's also, I was very much drawn by the allure of seeing different cities, working with different communities, and the adventure, I guess.
When did you decide to go to the UK?
I think I was quite sure from early on during medical school that I would want to spend some time abroad. UK was a double choice. One was the fact that I was born there, so there was a sense of like kind of almost going home, but not quite because I didn't have any memories of living there. And part of it was the system is very similar, so it was, and we kind of valorize the British medical system. Obviously now I know its flaws, I know the challenges, so I'm perhaps a bit more critical while still being able to see so many positives in the system. And so it was, the attempt to learn. But yeah, that was an early decision. And then towards the end of medical school, I confirmed that decision and started the process when I was in my 4th year out of 5.
Right. So it took about a year and a half to prepare?
Yeah, there's certain applications that you have to do. They have to start in the summer just after 4th year, to be able to be eligible to apply for the training, for the foundation program in the UK, which is the first 2 years of internships right after you graduate.
Right. And at that point, did you know you were going to go down the GP path?
Absolutely not. That was a real surprise for me. Initially, I wanted to be a psychiatrist. Mm-hmm. Then I worked in psychiatry for 4 months and it was just not for me. Mm-hmm. Then I worked in emergency medicine and I loved it. And then I also thought about palliative care and I loved it, but also found it was too much for me. And then I did a job in general practice in family medicine close to Liverpool, and I just loved going on house calls. I loved talking to different people. And I was torn. I was very torn between emergency medicine and general practice for a long time. So actually it took me a while to make a decision. And that's why I did my master's as well, partly because I didn't know what to do. And I thought, let's explore this thing called anthropology, which I had kind of discovered by accident before medical school. And that kind of led me back towards communities and social medicine.
What is anthropology?
You could describe anthropology as asking the question of what does it mean to be human? And if you think about the different pillars of anthropology, it answers that question in different ways. So there's the group of biological anthropology, which includes forensics, and that looks much more at, genetics and human behavior and more, the biological remains of people. Then you can look at more social and cultural anthropology, and that looks more at how do we interact as communities and why do we do what we do, from a more cultural and social level. And then you have archaeology, which is sort of a separate pillar of anthropology. And within cultural and social anthropology, you include medical anthropology, where it looks more at the cultures of medicine. So whether we're talking about Western medicine, termed biomedicine, or whether you're looking at, for example, traditional Chinese medicine, or certain ritual types that you get, for example, in Namibian tribes, in the Kungsan, where you look at the dance culture and how that relates to our healing.
Wow, so that's actually quite complementary, I guess, to medicine.
Very, very, especially when you're working in multicultural communities. But even if you're working in a community that is all relative, on paper at least, homogenous. If, for example, when I was working in Glasgow, most of my patients were white Scottish. There's still a cultural barrier there between the medical system and the people. And having a better insight in how to reach out to people is really, really helpful. And it's something that we can learn a lot from. I think, for example, we could do a lot by doing more ethnography, which is the way most of anthropological research is done, through ethnography, where you generally just embed yourself in the community and just get to know people, get to know the culture, maybe have informal interviews, and just really kind of pick out what is going on in terms of interactions and choices and how they're made.
When in your timeline did you go and decide to do the master's program?
That was towards the end of my second year of internships.
So you went to the UK,
Yes.
Went into full-time medical training,
Yes.
essentially,
Yes.
and then you took a break?
Yeah.
Right.
So then I decided to take a gap year, as many people do at that point. But instead of going to Southeast Asia, as most people do, I decided to explore the world through books and papers from the comfort of my desk in London for that.
So you actually moved to London?
I moved to London for my master's, yes.
Wow. It's been an exciting year.
Exactly.
Living in
It was, I was partly driven by the desire to live in London, see what life was like in London.
What is it like? Other than expensive?
When you're a student, it's tough because it's so expensive. It would have been nicer to do that when I was in full-time employment as a doctor. I would have afforded to go out more.
Yeah.
But it was the best decision I've ever made in my life, I think. Going down and spending the year just immersing myself in anthropology and just changing my worldview a little bit.
And once that was done and dusted, you then said, okay, let's go and do some more postgraduate training?
Yeah, so my initial thought was I'd love to do a PhD in anthropology.
Just some more study, sure.
Some more studies, never enough. Then I spoke to my supervisor, who's a clinical psychologist and medical anthropologist. And his advice was, if you want to be a good anthropologist or a good researcher, if you've already got a clinical career, keep it. Because it really influences your research, and your research really impacts on your practice as well. And this I've heard again and again in different contexts. I went to NAPCRAG, the North American Primary Care Research Group meeting last November, and they talk a lot about practice-based research and research-based practice. So instead of just talking about evidence-based practice and evidence, that is very important, but also think about it the other way, the practice-based research. So really embedding the research within the practice so it has a direct impact. And you can also think about it in terms of research influencing, what you're coming up in your research, influencing how you think in practice, but also what's going on in practice and how your patients are dealing with things, influencing the concepts and the questions you ask and how you structure the research you do.
Yeah, that was very sound advice, I guess you got at that point, eh?
Yes, it was very good advice, and it helped in my thinking in how I progressed from there.
But it was probably hard because then you had to move out of London again, because in the UK you can't really pick and choose, can you?
Well, at that point you have to go through the application process for GP training, and I could have chosen to stay in London. I may have got a post in London. It was a personal choice to move. I missed being in the north of the UK, and I had friends in Glasgow, so I thought it was a good place to go to. It was also more affordable. In London I would have been still in a position where I have to share probably and rent, whereas in Glasgow I could afford to have my own place. Which, knowing how intense GP training would be, and I was right, having my own place would have been very important for me personally.
So what was it like being a GP in Glasgow, or a GP trainee at that time?
It was intense, it was busy, but it was very interesting. I worked in some really interesting communities. Loved working. I worked in the East End for a long time. So for those who don't know Glasgow has a real problem of life expectancy gap. You've got areas where the life expectancy is in the mid-50s, 54, 55. And then you've got some areas where it's high 80s. And we're talking within the same city. So something's going on there. And I worked in areas where the life expectancy was around 60 or maybe even a bit lower. And it was a tough challenge. You're seeing a lot of pathology, but the community spirit was great. And I really, really enjoyed, I really found it fulfilling to work in those communities. And I'm looking forward to going back.
So, yeah, you kind of skipped forward already. So once you were done with your training, you then decided to leave again.
Yes.
But you just mentioned, so you've always kind of kept the idea of maybe going back at a later stage. When you finished your training, you probably could have just stayed in Glasgow and your life would have probably continued on being a GP for the next 40 years.
Absolutely.
So what was it at that point that said, let's go back and do some more studying?
A couple of things. One was, I always had this thought in the back of my mind, I'd really like to do a PhD. And it's more a case of like this opportunity arose. This PhD was advertised in the WONCA news, actually. Mm-hmm. And I thought, this looks great. Because the title of the PhD is Collaborative Care Networks in Functional Disorders.
So WONCA News is the newsletter that is sent out to everyone who subscribes. I
would recommend just keeping an eye on it because some opportunities like this do come up. And I had been thinking, we're working in this place where people have low life expectancy, where they're not getting the access to the care that they need. But other people in the same city are getting the access to care that they need. Why is there this gap? And what I often think about is we have the knowledge, but it's just not reaching the right people. And so the way to get there is by improving that care around the patient with multiple disciplines. And so this came up and it was perfect because it was literally talking about how do we bring those people together. The other side of it was I'd never lived in continental Europe. It was something that was on my mind as a possibility. I have friends in the Netherlands. I thought, what a great opportunity. I get to live in continental Europe. I get to challenge myself potentially to learn the language, which is...
Did you?
To some extent. I can email in reasonable Dutch, and I can read reasonable Dutch. Conversations is another story. And that was, I thought, here's a great opportunity, 3 years in the Netherlands, get to experience, continental European life, Dutch life, learn language, and explore the possibility. And so I didn't come with the thinking, I'm definitely going to move back to Glasgow. I came with the thinking, I might move back to Glasgow, I might stay. Mm-hmm. And that was great because I challenged myself to learn the language. I challenged myself to get to know society here. But I also didn't have the pressure. So I could focus on the PhD itself.
And then you also did something which I found very special and probably very, very rare under medical doctors. You then decided to go into qualitative research rather than quantitative research, which was probably a very conscious choice.
Yes.
What was that?
I would actually say it was a conscious choice to move more towards, let's say, conventional research within the medical field than what I would have wanted to do. Mm-hmm. I'm glad I made that choice, though, because I would have, my original plan was to do a PhD in anthropology. Mm-hmm. And so that would have been full-on ethnography.
Mm-hmm. Which is also qualitative.
Very deeply qualitative.
For those who don't know the difference, what is the difference between quantitative and qualitative research?
So with quantitative, you're mostly working with numbers. You might be working with a cohort. So, for example, there's a cohort in the Netherlands called Lifelines, which has, 100,000 people where they filled in surveys. They filled in questionnaires about their health at different points, and you might have done, and you'll do it longitudinally, so you do check every so often. And so then what's quantitative, what you're doing is you're taking out the numbers and analyzing the numbers. With qualitative, you're looking rather than at numbers, you're looking at experiences. You're looking at more detail about the nuance of what's going on behind the number. So you might do interviews or focus groups. You might do surveys, but where you're trying to pick out a bit more about what people are going through in a certain situation. Or you're doing ethnography where you're spending time, as I described earlier, you're kind of observing a community, getting to know how people interact. And that's going to be more based on field notes and interviews probably.
And what is your research about now?
So the research is about collaborative care networks in the treatment of functional disorders. And here we're talking about how do we implement or improve what's collaborative care. So how do we improve the interactions and the networking between a team?
So interprofessional...
interprofessional collaboration would be another way of looking at it.
Right.
And so we're doing a series of studies, mostly qualitative, looking at what sort of quality indicators we should be considering in such a network.
And what are they? Can you share that? Or
I can share them. It's a published paper. You can find it. The top ones that come to mind are, number one is having a shared vision of care for functional disorders in this case. Then there's things like having shared decision making with patients, having an individualized pathway for patients, having open communication. And so that's actually really exciting because none of them are outcome based. They're all process and structure. They're very much focused on how do we work better as a team? What sort of things should we be thinking about in improving the team? That was one of my earlier studies, and that really influenced the direction that we took throughout. So then we did a study where we tried to identify strategies to barriers, and we used a very different research method. And then we're doing a participatory research project, trying to really improve a network.
What would you say to a student who's at those crossroads? Should I do quantitative, qualitative research? I know a lot of students are very afraid of qualitative research. It looks like a lot of work, a lot of talking, a lot of transcribing, I guess. Would you say go ahead, or would you say stick to the numbers?
I would say it's a lot less scary than people think it is. Yes, it's a lot of work, but so is quantitative. I think it depends a lot on what you find exciting, and I am always a lot more excited by qualitative. I am much more excited by the nuance that you bring out from an interview and the themes that you can start to see arising. And I find that very exciting, that a bunch of, like, say, 10 interviews, and you come up with these really interesting themes that really challenge what you might have thought about a particular population group. I do find quantitative quite interesting as well. I just don't find it that exciting to me. Some people get incredibly excited when they start to see, the results of a regression, for example. And I find it interesting, and I find it useful, but I just don't find the work that goes into it exciting. And so you need to think about what you find exciting yourself and what you're willing to put the time into.
At what point during this journey did you learn about EYFDM?
I was very lucky. I discovered EYFDM from my predecessor's predecessor. So Claire Thomas, who was president before Kasia, she's an old friend of mine. We were friends from about 2010, when she had very willingly come down to Malta to run a training new traders when I was in IFMSA, the International Federation of Medical Students Associations, for those who don't know. And we became very close friends very early on. She even hosted me in Liverpool when I first moved up, and I lived in their spare room for a while. And then in 2017, early 2017, myself and a few friends were visiting her in London when she was living in London then. And she cheekily told me, I need a treasurer in VDGM at the time. Do you have any ideas who might be good? And we talked about it, and I ended up applying. And it was very much her trying to pull me into the organization. I applied, and I was elected duly as anyone else would. But that's how I discovered it. I was aware of its existence from Claire talking about it, but that was how I discovered it. It's just about to start GP training, and I was elected straight away.
Oh, perfect.
So yes, I've maximized my time in the executive, and it's going to feel strange not being the executive anymore.
Which is going to happen when?
In Dublin in September.
All right. So, and why is that?
Because my term ends. I was president from beginning of 2021 up until Brussels, so until June of 2023. And then I've got 1 year as immediate past president, supporting Stuart, the current president, during his time during his first year of the presidency. And then I will step down and will elect a new president-elect. So if you're thinking about it, nominations are open. Really consider it and apply.
And you can find all that information on the website, I guess.
Absolutely. And also keep an eye on our Instagram,
where you'll learn more about the role. What was it like being a president for you?
It was a challenge, but a very good learning challenge. I think the best advice I got before I applied was 2 bits of advice I'd share here. One was from Claire, who told me, you're not applying for the job because you think you're already going to be brilliant at it. You applied for it because you think you've got the ability within you to do this, and that you can improve your skills as you learn, as you do the job. And so it was a very good opportunity to reflect on myself, reflect on my people skills and my management skills, and to improve them as I went along in a rather safe environment. There is the responsibility. You are leading the organization, but it's a great opportunity in a very supportive environment with a great team in the executive, and support from the council, and support from past presidents and past executive members who are still going to be around. And I had a lot of that. And the other advice I got from Harris Ligidakis and from Andre Rushford, who told me, if you want to be a good president, have a clear vision of where you're going. And so that was then the process. I thought clearly about what vision I want to have, what do I want to focus on during my time, and that kept me going throughout my time. And that was very effective.
Thank you for sharing that. Nick, from listening to other podcasts, you probably know we have a little game that we play in this podcast. 50 word pairs. You can always skip or say next. The fun part about it is not to think too much about it, but to actually decide what comes to mind first, and we can discuss some of the pairs afterwards if
Sure.
there's anything you want to say, why you chose or why you didn't choose a certain option. Are you ready for the game?
Sure.
House or flat?
House.
Stay in or eat out?
Eat out.
City vibes or countryside quiet?
City vibes.
Terrace or balcony?
Terrace.
Plane or train?
Train.
Rails or roads?
Rail.
Music or podcast?
Music.
Laptop or tablet?
Laptop.
Summer or winter?
Winter.
Too early or too late?
Too late.
Morning bird or night owl?
Night owl.
Beard or no beard?
Beard.
Mask or no mask?
Mask.
On site or online?
On site.
Today or tomorrow?
Today.
Malta or UK?
Ooh, pass.
England or Scotland?
Scotland.
London or Glasgow?
Glasgow.
Undergraduate or postgraduate?
Postgraduate.
General practice or family medicine?
Family medicine.
Salaried or self-employed?
Self-employed.
Salaried or locum work?
Locum work.
Research or clinical practice?
Research.
Education or research?
Research.
EYFDM or WONCA?
EYFDM.
Treasurer or president?
President.
Council or executive?
Executive.
Pre-conference or forum?
Forum.
Acting president or immediate past president?
Acting president.
Qualitative or quantitative research?
Qualitative.
University of Groningen or University of Nijmegen?
Pass.
Preventative medicine or rehab medicine?
Preventative.
Geriatrics or pediatrics?
Geriatrics.
Mental health or acute care?
Acute care.
Talking or listening?
Listening.
Treating or caring?
Caring.
Medication or intervention?
Intervention.
Sitting down or standing up?
Standing up.
Running or walking?
Walking.
Physical health or mental health?
Mental health.
Medically unexplained symptoms or persistent somatic symptoms?
Persistent somatic symptoms.
Persistent physical symptoms or functional disorders?
Functional disorders.
Communication or action?
Communication.
Facial expressions or gestures?
Facial expressions.
Emotions or facts?
Facts.
Consumerism or minimalism?
Minimalism.
Scottish whiskey or iron brew?
Scottish whiskey.
Pastrici or Fetira, not sure how to pronounce that, Bisseid?
Pastizzi or ftira bezeit. Pastizzi.
Fish and chips or Sunday roast?
Sunday roast.
Meditation or workout?
Meditation.
Well-being or keeping busy?
Keeping busy.
Autonomy or prosperity?
Autonomy.
There you go. Done. There were quite a few interesting word pairs in there.
Yes.
Was there any that you wanted to talk about?
I think I'm particularly purely from a knowledge base. I feel quite strongly about MUS versus PSS, so medically unexplained symptoms versus persistent somatic symptoms, and also the question of
what is the difference?
Yeah, so MUS is medically unexplained symptoms is an old term, which really we should not be using anymore. Persistent somatic symptoms is a much better term because it's a positive diagnosis. You're actually saying this is what it is. With medically unexplained symptoms, can you imagine telling a patient, I know what you have. You have medically unexplained symptoms. It is illogical and it is really unhelpful to the patient. And it's also just incorrect. The reality is we do have explanations for these disorders. And so when we talk about functional disorders and persistent somatic symptoms, which are basically the same thing, well, some differences. But
it's a perspective question, I guess.
It's a bit of a perspective. And actually, that's a good point. The perspective is whether we're thinking about these that are disorders that are mostly caused by biopsychosocial factors, which would probably be more the functional disorder side. The other way of looking at it is to think about these disorders, which would include persistent somatic symptoms such as chronic pain from osteoarthritis, as disorders that are best treated using a biopsychosocial approach. You see the difference? Mm-hmm. On the one hand, you're talking about what's the causing, what are the precipitating, perpetuating, and predisposing factors. But the other side, you're thinking about how do we treat them? And by treating them in a combined biopsychosocial approach, which leads us to the importance of collaborative care.
Which is your topic of research.
Absolutely. And I think that's an important point to make. We have got explanations for these. They're positive diagnoses. There are very good diagnostic criteria for these disorders, which includes, fibromyalgia, IBS, chronic fatigue syndrome, functional seizures, functional dizziness, or what is now called PPPD, persistent perceptual positional dizziness.
All right.
That one.
Never heard.
Those
never
are
heard
all
that
kind
abbreviation.
of fall under functional disorders.
Yeah.
And we know we can treat them, so we should think about them in that way, and we really should leave terms like medically unexplained symptoms in the history book.
Another thing that you also picked, which I found quite interesting, you also picked mental health over acute care.
I picked acute care, actually.
Oh, did you? Oh,
I did.
sorry.
But
Why did you?
it's a tough choice.
Yeah, why did you?
I think I get, acute care is a nice way of, it's easy, to be honest. Most of the time, acute care is quite easy. Mental health care, you have to put in a lot more thought and effort in the interactions that you have. So it can be more tiring. Acute care, you've just got a physical issue, you deal with it. And generally speaking, it's a very protocolized, how do you deal with this? And you fix it. And I find it sometimes quite relaxing. I quite miss working in a minors department and an emergency department and dealing with the acute issues that come in there. But it's a tough choice because on the other hand, I also really enjoy is perhaps the wrong word. I find a lot of fulfillment in supporting people with mental health issues.
Yeah, I see. I guess that brings us to the end of our podcast. You have a very busy day today and also an appointment coming up. Is there anything that you want to share with our listeners before we let you go?
I guess the main thing I'd like to say is, working in EYFDM has been a really positive experience. I've really enjoyed it. I've learned so much about myself. I've made so many lifelong friends. And I don't think I'd have got through GP training if it wasn't for EYFDM. The sense of community and support that you get is uncomparable. So I would really recommend, making the time for, coming to the forum next year, come to Dublin. It's such a great space to connect to people. And again, when I started out, I had no idea how to do the job of a treasurer. I had no idea how to be a president. I had no idea how to lead an organization. But I learned so much from the people around me, from my predecessors and from my team, that has made me so much better and also has had a big influence on my research and on my clinical practice. It genuinely has directly impacted on the research I'm able to do and the way I manage to do my work. The skills I have learned, I wouldn't have been able to learn them from other places. So it really is worth doing, even if it is a volunteer role, even if you're putting in your time and effort and probably money. It is absolutely worth it.
Thank you so much for sharing all your stories. When would be the next opportunity to actually see you in live for all our listeners?
So the next thing would be at the end of September in 2024, we have our pre-conference and WONCA Europe conference in Dublin. I will definitely be there. I will be joining the parties and joining all the workshops.
Can people come up and talk to you?
Oh yes, please do. Just come up and say hi. You'll see me around. Big beard, probably a rainbow lanyard and a colourful shirt.
Thank you so much, Nick, for your time. And we look forward to seeing you in Dublin or one of the future events. Thank you so much.
I look forward to meeting you all in Dublin as well.